Madam Chair.
Welcome back, folks. This is Health Corrections and Institutions Committee. It is Tuesday, April 15th, tax day. So hopefully everyone's gotten their income taxes done or filed an extension. D-Day.
D-Day.
So we're working on H32. And this is pertaining, we have DEVA, which is Department of Vermont Health Access. And DEVA is our department within the Agency of Human Services that really works with our Medicaid dollars. So maybe you could also, Alex, just give some background in terms of what DEVA is, because this committee is not used to dealing with your department or many other departments within the Agency of Human Services, except for the Department of Corrections.
Of course.
So it might be good just to give a brief background, but it's also to work on page 11 of the proposed changes in H32, which deals with a report back that the Department of Vermont Health Access in consultation with DOC would submit in terms of the number of previously incarcerated individuals reentering the community, and then how effective the MOUD program has been for them when they reenter. So, Alex, welcome. If you could identify yourself for the record.
Of course. Thank you so much, Madam Chair. For the record, my name is Alex McCracken. I'm the Director of Communications and Legislative Affairs for the Department of Vermont Health Access. And thank you so much for having me this afternoon. DEVA so rarely gets an opportunity to come and speak with your committees, so I appreciate the opportunity to come in and weigh in on this bill and give you a little bit of background about what the department does. I'd be happy to do that. I see some faces that I know from my travels throughout the building. Hi, Phil. But thank you so much for having me here today. So just to give some background about DEVA, we sit within the agency. We are primarily tasked with the administration of Vermont Medicaid. We oversee the entirety of the Medicaid program from enrollment through services. We coordinate with providers to provide reimbursement for services provided to Medicaid members. We also oversee and manage the insurance marketplace. So folks who get insurance through Vermont Health Connect or the qualified health insurance plans through Vermont Health Connect, those are all within DEVA's purview as well. So really, we are the biggest insurance provider in the state of Vermont, if you look at it like that.
And you'll also be involved if we continue with the 1115 waiver for DOC, where prior to 90 days prior to reentry, an incarcerated person would be eligible for Medicaid. So you would be, your
Yes.
department would be involved in that pretty directly.
Absolutely. The 1115 waiver is done through the central office of the Agency of Human Services through the Medicaid policy team. But we are very plugged into that work. And as you mentioned, we're currently in the process of implementing that for next year.
Just really updating your IT system so you can,
You make it sound so simple.
Yeah. instead of canceling them, you can pause them, but you don't have the right software, and then how to reinstate them while they're incarcerated.
So that is work that's ongoing with the department right now that I know is across the purview of this committee in the past. If there are questions about DEVA or the function of the department, I'm happy to answer them now or even later. My contact information is accessible, and I'm happy to be a resource to all of you with any questions you might have when it comes to Vermont Medicaid. I can go ahead and talk a little bit about H32 specifically. As Chairman's noted, I'm only going to be talking about the reporting requirement on page 11. That's specific to the Department of Vermont Health Access. We're very glad to have an opportunity to weigh in on this language. We have some significant reservations with the way that the language is currently worded within H32. The core of the issue stems from who has the data in question. DEVA does not have the visibility on people who are incarcerated. Incarcerated individuals are not enrolled in Medicaid. They don't submit claims or reimbursement through the Medicaid program. So we don't have any visibility on what's going on with their Medicaid or MAT when they're incarcerated. When they're released, and if they enroll in Medicaid and start submitting pharmacy claims, we would be able to see those, but we would not then be able to tie those to their status as a previously incarcerated individual. So we have half the equation And we believe that the other half of the equation is probably in either DOC or Blueprint's purview. So putting those two together could present some challenges and could create a significant administrative lift. There has been some prior work done in this area, limited to a specific time frame, and it required DIVA, Blueprint, and DOC staff to coordinate in manually matching member IDs to previously incarcerated individuals receiving MAT with Medicaid claims. That's obviously a significant one, and we would ask that that not be an annual reporting requirement. And we hope that perhaps additional testimony from ourselves or Blueprint or DOC may be helpful in finding a way to access this information that wouldn't present a large administrative lift to the department.
Who would have most of that information? Is it DOC that would have it?
If you're talking about people who are currently incarcerated, that would be within DOC.
That would be the MOD, because the way it's drafted, the way it looks is like DIVA's in the driver's seat.
Right.
In consultation, should it be DOC that's in the driver's seat in consultation with DIVA?
I wouldn't want to speak for DOC, and I wouldn't want to force them to speak at this moment either. But that's certainly, there are options, and we'd be open to having that conversation to see what fits best to make sure that you're getting that information and it's not creating an issue on our end.
So I'll go to Kevin because Kevin's the one that was interested more in trying to track this as they re-enter. How effective is the MOUD program?
Forgive the wrong use or a bad use of language, but I understand you losing visibility when a person is incarcerated. But their social security number follows them before, during, and after. I don't understand why tying the databases together based on social security number shouldn't be reasonably easy, and so the visibility could be available to you when they are being released.
I don't pretend to know enough about IT to offer a substantive answer to that, but I know that, things are often a lot more complicated than they might seem.
I oversimplify all the time. I understand.
And that's great. We need that. But I'm not sure if that's a feasible thing to do. I think that would not be implementable as you've described.
I don't think the Department of Corrections actually always has people's social security number. That might even be a voluntary piece of information that is not always provided at intake, as you can imagine, when someone is highly dysregulated. Nor do I think, do I know if we're actually entitled to some of that information. But you can imagine there's been historic, underinvestment in these data systems, which the legislature has worked to ameliorate over the last few years. But a lot of these systems, DOC system, and I know the MMIS system, they're legacy data systems that are very clunky and they're not designed to interoperate.
Would HIPAA play into this at all?
It would, I believe it would. And the privacy and legal concerns are also a significant barrier to that data sharing and cooperation, and why this initiative previously with Blueprint, DOC, and DIVA was significant.
Could you actually find language that shows us that it's prohibited? You're saying, I think. Is there actual language there that says you can't get it?
I would need to take that back to have an attorney from the department offer.
Great.
So if HIPAA is an issue, would you need to have a consent of release of information from the incarcerated person who's reentering the community to share information about their MOUD that occurred while they were incarcerated and while it's occurring in the community?
I imagine that we might.
Well, and I think to Alex's point, what we did a few years ago, I think it's actually predates my time in the department, is DOC worked closely with DIVA and Blueprint. And I think at that point also Medicaid policy was part of DIVA. It's shuffled out a little bit, but it was a very intensive collaboration to try and, as Alex was saying, manually pull this data and look at it. I think there's some potential with the 1115 waiver that we might be able to design that in such a way that it has a unique identifier for anyone who's restarting their Medicaid coverage while they're incarcerated, and then we could look for claims for MAUD. And also this would be in the aggregate. So we wouldn't be as concerned, I think, about some individual level health data. That might be the best way to do this, but I think it would be premature at this juncture, just given that we haven't implemented the 1115 waiver yet, and there's still a lot of questions around whether it'll even come to fruition given some of the changes at the federal level. But we are proceeding as if it will.
Right. Yeah, thank you, Isaac. I think that was well put. And the federal changes as they occur, we will continue to respond to them. As we sit now, we are proceeding on course, assuming that 1/1/26 will be implementation date for that. So, and I would encourage the committee as well, and I'll mention this to Chair Emmons as well, that for additional information regarding the 1115 waiver process specifically, I would recommend reaching out to Ashley Berliner and Medicaid Policy. They'll be best positioned to speak to that.
And what's her last name?
Berliner, I believe she came and spoke to you guys a little while ago.
Yes,
Yeah,
she did.
yeah. So she'll be your best point of contact for 1115 waiver questions.
You guys have, not necessarily right this second, but do you have proposed or language you've thought of that would better address this issue?
We can certainly come back to you with some proposed language. I don't have any with me today, but
Yeah,
but we can work on our end and with DOC and Blueprint to try to find something that feels acceptable to get at what you guys are looking for.
it doesn't violate any laws.
Yeah, we try to avoid that.
It's always handy. It's always pretty handy.
That would be helpful.
Okay. Yes, we'd be happy to do that and come back to you guys with.
You wrote that down. Yeah, Sean?
So what happens now? Is it covered in the 1115 waiver?
What do you say?
Like what we're talking about here with them, with this ask in the bill in 32, we're saying annually come up with this big thing, and you were like, yeah, that's crazy. Like, is there something that how does it happen now in the real world?
Well, currently, I mean, we have this study from, I think, 2022, where we were looking at continuity, which I think was actually 70% of folks who were receiving MOUD in facilities who then went out into the community, and there was a Medicaid claim within 45 days for
Yeah.
MAT.
Yep.
So that's kind of the benchmark that we use, but that was a kind of point in time study. So there's no process now that we have the ability to query that data.
Okay.
It would require, like we were saying, like a manual data analysis and kind of heavy administrative burden on the departments. I think part of the issue is that, and this is what the 1115 waiver is designed to bridge, is these gaps between departments and jurisdictions, right? The correctional system has a lot of gaps from the Medicaid system. It's actually built that way in federal law, which is why we're working with the waiver to try and create these pathways that move between these different departments and jurisdictions.
Got it. Okay.
Well, the only thing that happened while you're gone, other than Sean asking a really good question, is that Alex and Isaac said they would work together potentially to have some better language that would be suitable for them.
To bring to us.
And sorry, Mary, I didn't mean to cut you off.
That's fine. How long ago did you do that study, or what you just?
I think it's in 2022.
It was 2022. It
Yeah.
examined 2019 to 2022.
Yeah, and they were, I've looked at some of it required all this kind of custom coding of the Medicaid billing system. I mean, it got pretty technical.
So what did it accomplish for you?
I mean, I think it showed that there is high uptake of MOUD within the community with people released. I mean, 70% is a pretty high number for medication adherence.
I think we can also share that one pager with you as well that we have in 2022,
Well, that would be helpful. If you could do that and send it to Phil,
of course.
really helpful. So what I'm understanding is that the two entities are gonna try to work through, massage the language a little bit to make it workable.
Yes, we'd be happy to do that. We can take this back to our respective departments. We'll involve Blueprint. And I also recommended while you were out of the room, Madam Chair, that Ashley Berliner would be a good resource for further 1115 questions. As I know that is part of this conversation as we move into next year.
What is the time frame for you coming out with something?
For proposed language, we can probably have something by the end of the week.
Great.
That would be lovely.
Kevin?
So am I understanding that a person who's incarcerated does not have to try to identify their social security number?
That would be
Yes.
for DOC.
Yeah, I do know that we oftentimes do not have someone's social security number, especially if they're a detainee and they're coming in and perhaps they're heavily inebriated. We're just, they're sleeping it off and then they're they've made bail and they're walking out the next morning. I don't think we're actually required to ask them. I think they're required to.
But this doesn't apply to a detainee. This would be someone who would be in custody for a period of time, and then we're releasing them and they've lost Medicaid, if I understand what we're working for.
Right, but
Yeah, the sentence population specifically. I can ask some of our operational folks, but I'm not
what
surprised.
would you do
we're
with
not-
their social security number?
The way that we track individuals within our data system through OMS, the offender management system, is usually what's called a jacket ID, which is their unique individual identifier. So we don't use socials. Also, you can imagine sometimes we're working with folks who don't have social security numbers, because they're undocumented folks, they're not citizens.
Okay, so then that leads right to the next. And forgive me for sounding so old, but why is anyone receiving Medicaid if they don't have a social security
They're
number?
not receiving Medicaid. When they're incarcerated, they lose all
I know, we're trying to
insurance.
set it up so they have it again when they get out. So it's presumed that they had it before.
It's based on your income.
It is. It's based on income. Your eligibility is based on your income for Medicaid. So many people who are incarcerated or are being released from incarceration do qualify for Medicaid, but they need to enroll in Medicaid in order to be a Medicaid member. The 1115 waiver would allow was it 30 days prior to 90 days prior to release for those individuals to enroll. So that would let them start that enrollment process earlier. But when they start that enrollment process, they would need to supply everything that DIVA needs in order to become a Medicaid member.
So what is it for a single person? Is it 16,000, 18,000?
The eligibility limit?
Yeah,
Oh, I should know that.
just the gross income. Must be around 17,000.
I think for a single person is around that area, 17 to 20. I will get a firm number for you though.
Eligible for Medicaid.
Yeah.
That's the base.
Because it's based on your income.
Yeah. But it's
Well-
based on your income, but it's also based on whether or not you're a citizen, right? I mean, so there's undocumented people that are in the incarcerated status, okay? I wonder how that would actually work. Okay, I'm not even getting that. That's a separate question. But you're saying that they would have possibly had Medicaid prior?
No, what I'm
No,
saying is
okay.
that we do not actively collect people's social security numbers. It's not that, the field in which that we track people using OMS, our offender management system, our database for the department. You can imagine that every person who has a file in our offender management system needs some kind of unique identifier.
They have an inmate, they have an inmate number.
Yeah, inmate number, which we call a jacket ID. And so that is the unique field per individual. We do not use social security number because not everyone has a social security number. So we use our own custom field. It's like 15, 20 digits long that identifies individuals.
But so after, so now they get assigned this 15-20 digit number and then they get released. And if we were to go with the 1115 waiver, you're saying that people that don't have a social security number that have this LMS could qualify for Medicaid?
So I was responding to Representative Winters' question about how do you collect social security numbers? How do you track people within your system? Unrelated to Medicaid.
Okay.
So the Medicaid question would be more for Alex.
And Medicaid enrollment does require a social security number. I believe.
Okay.
It's you require several things in the course of enrollment to provide identification and verification of income and
Now,
such. So that process is separate from the DOC process. And if incarcerated individuals were engaging in that 90 days prior to release, we actually might have an easier time tracking all the things that you're trying to see here in this report.
But if they were undocumented, 1115 waiver, 90 days prior to release to sign up for Medicaid, still would require a social security to qualify for Medicaid.
They would
So
not be eligible.
they would not
They were
be eligible.
Right. Yeah.
John?
So I think you may have answered this before. I'm gonna ask it anyway. So is it automated that they get to sign up 90 days
Well,
before?
we don't, need the waiver we've been approved the waiver. Right now, no one can sign up for Medicaid or any insurance until they are physically released from an incarcerated setting. So that's where the issue comes in terms of them getting their medication. It could be their heart, could be high blood pressure, could be anything. You put MOUD aside, any medication that they're on, they can have a prescription at the pharmacy, but they may not be able to pay for it. And they have still not been able to sign up for Medicaid or for their any other health insurance. Because when you're incarcerated, you lose it all.
Mhm.
The 1115 waiver would allow 90 days prior to their release date to go through the application for Medicaid. So that upon release, they are covered, and then you don't have that gap for their medication. They'd be able to pay for their medication and other health services. Because that's where you lose people right now. That's where you lose them.
Right.
So does that help?
Yes, absolutely.
To Isaac's point as well, that would also help kind of break down the departmental barriers and allow us to have greater visibility on who's coming out of the incarcerated population into Medicaid and allow us to be much more responsive to requests like this. So while this might be a really tricky ask this year, hopefully in future years, it would be less tricky.
Yeah, it's a transformational project. I really don't think we can undersell, like, this is a huge step forward for our system. And there are so many good reasons to do it. You know, for folks who are going through the system, it will make their reentry process so much smoother
Mhm.
when their Medicaid is already turned on and they go to the pharmacy and everything goes without a hitch, because we've heard that's an issue. Where folks have to reapply and, you know, it can be really difficult if they miss their eligibility, right? And then also in terms of just state taxpayer dollars, we're gonna be able to take advantage of the funding match that we get from the federal government for these services. And then we'll take the money that we save and reinvest it into providing more services for incarcerated folks. That's part of the federal requirement for the waiver. And DIVA is also getting, was it $3.5 million of capacity building funds, so that we can also rebuild our Medicaid claims processing system from the feds. So it's a great program.
And the 1115 waiver doesn't kick in until January of next year,
Correct.
but you have to build up your IT system. So Brian and then Mary.
It's sort of a remedial question, I think primarily for Kevin, if it was you who was requesting this data, but also for the committee. I mean, I want to have all the information I can about how well things are working, but suppose we could get this information much more easily than is being indicated. Does that provide us with a decision point? Like, what does this data do for us? Suppose we could get it.
Well, if it identifies that they've been getting medication from this pharmacy or that pharmacy, this is the doctor, whatever, I mean, theoretically, you don't have to rebuild the history. And specifically, they are not eligible for Medicaid if they don't have a social security number, so you don't go through all that effort to try to set Medicaid up. I mean, and it's the most basic identification within the United States, I believe, to have a social security number. So it just is a baffling surprise to me that we have to ask for social security number when someone is held incarcerated. I'm surprised.
I dig that
forgive
question.
my astonishment, but that's.
Yeah, no, I dig that question. I'm trying to figure out, is this about, are people recidivating? Is this about, are people having good continuity of care?
Yes.
Yeah.
It just,
Yes to all is yeah.
all the above. It just seems like it should be much more it should be seamless in terms of social security number when we're trying to help them get Medicaid.
But your social security number is, I wouldn't give out my social security number.
Well, you wouldn't be incarcerated voluntarily either.
Well, I don't think I would want to give it to someone
people
over
probably don't
40
even know
while I'm
they're-
incarcerated.
I bet a lot of folks don't even know their social
Right,
security number.
most people, a lot of
I
people
think that's a
don't.
big issue.
I mean, that-
We're assuming.
They hate to be in the army because it's on every bag you own.
Facility.
But social security,
I'm just flabbergasted, that's all.
so Brian, your question was how effective the language here?
Yeah.
What are we really trying to get?
Yes.
And I think what I was understanding from this is they're on an MOUD program while they're incarcerated. Then they re-enter the community. Are they continuing with that MOUD program on the outside, and is it being effective?
And effective as they continue to take it.
Right.
Well, so then the 2022-3 study, whatever it was with the 70%, I mean, that's a decent measure, is it not?
Yeah, it seems like it.
It's huge. It's a lot of people.
Yeah, I mean, I think that there's this other question for sure, but yeah,
I'm with you.
yeah, okay.
So Mary, and then Will, and then Sean.
Yeah.
I think my question was somewhat answered, so I'll push on. Next person can ask.
Will, and then Sean?
So you said that with the money we're gonna save from the 1115 labor, that it was gonna go to additional services to help incarcerate people. Was it ever and maybe there's federal stipulations, but was it ever considered if we might use it for victim restitution or victim rights?
It's a federal requirement to reinvest the savings in our services.
It's limited what you-
We received their approval from the Biden administration.
I'm glad I remember you having said that, just wanted to clarify.
Sean?
And then Alex, just confirming, because I'm still trying to wrap my head around this. You have to have all the computer and everything has to be implemented by the end of this year.
Yes.
There's a, sorry, go ahead.
Is that gonna happen?
So we put money in the budget. There was also money in BAA, which got vetoed, but is now incorporated in the general fund. Was it 500,000? $1 million on your end, and there's money on Diva's. It's in the budgets to do this.
We are working with ADS. The work is continuing apace and we are scheduled for implementation on 1/1/26.
It's a huge lift.
It's a huge
It's a
work.
huge lift. I mean, Aviva is working on this every day.
Oh, sorry, yes.
It's a massive undertaking.
Okay, yeah, and what if that's not up operational by December 31st?
I don't think I think that we are moving with the expectation that it will be working by that point. I don't have the ability to conjecture a contingency plan at this
Okay,
point.
gotcha. Thank you.
Yeah.
Do you have a safety net that we can get an extension or something if it are IT? Because usually IT in the state does not go in, shall we say, when they're implementing. So I would like you to make sure you've got a safety net under this.
We're very cognizant of that. Absolutely.
Well, it's two different things, being cognizant of it and doing something about it.
But the legacy system could continue past the end of the year were it necessary.
Yeah, that's a good question also for Ashley.
I was
Berger,
just
It
gonna
needs
say,
to be
this is,
asked and probably answered pretty quick.
this is definitely a question in Ashley's wheelhouse around this.
So Phil, it might be good to have Ashley Berlin. She's with Diva to come in. I think she came in at the beginning of the session and talked about it. So it'd be good to have her back. Now that folks a little bit, have a little bit more understanding of DLC in the world.
And I'm betting this is Ashley again, but this new system, and just say it's her if it's her, is the data going to be queryable in a way that you could with the databases with which I'm familiar?
That is definitely
And Ashley.
an Ashley or
Okay.
other person question. I honestly don't know.
Okay,
The goal of having Diva and DOC gather this information that is on section 3 is if a person has been on MOUD while they're incarcerated and they've re-entered, it's to really see if they have refilled that prescription. And continue to refill that prescription 6 months, at least 6 months after reentering the community. The goal, the intent, the thinking behind this was, well, if we're putting them or continuing them on MOUD while they're incarcerated, how effective is this if when they come out in the community, they stop doing an MOUD program and go back to opioids? That's what that's what some of the members in the committee are trying to get at. How effective is the MOUD program while they're incarcerated if when they go back out in the community, they're not doing it and they go back to using opioids? That's the crux of the issue.
Yep.
Absolutely. And I'm happy to work with DOC and Blueprint and see what language we can put together. I also did send along the one-page infographic to Phil that covers the study that was done in 2022. That does provide some insight into the line of questioning there.
Were you part of that study?
I was not. That is before my time at the department.
So if we had questions on that, who would we go to, Ashley?
Who would we go to with that? I think a lot of the people involved in that are no longer with the department or with the agency. So I would have to look and see who involved in that project would still be available to speak to it.
Oh, great.
Susan, who would
Yeah, I
that be?
think, probably, because I know that Annie had worked on it,
Annie.
but I think, asking more, our data lead, I know has worked on it before. And then we'd have to circle up with Dr. Story and Blueprint, they also were part of it.
And I know that Blueprint is interested in these conversations as well, and they can be a resource for this information.
So as we move forward here for this language on section 3, DOC and DEVA are gonna get together, try to figure out what's the best way to collect this data and report back to us by the beginning of next week, end of this week,
End of this week is good.
end of this week. Doable?
Yeah, we can do that.
We go to the cafeteria. Maybe not today, maybe tomorrow. That. Does that sound like a plan for committee members?
Sounds like a plan, Stan.
That makes sense to folks? And then you've also heard what the intent of the language is, to make sure that people are continuing on the MOUD and not putting to waste everything DOC has put into them, and then they go back to using opioids.
Absolutely.
I want to see how effective the MOUD program is from incarceration. Make sure it keeps them off of the opioids once they reenter the community. Okay. Thank you.
Thank you so much, Madam Chair.
Thank you. I'm
Thank
sure
you.
we'll be back.
Thank you.
What I'd like to do with the committee while we've got some time, I really want the committee to look at the bill and start reading it. I know it's boring, but I want to see where the flags are for folks and make sure that we really understand what the bill is saying. It's going to really help in testimony, and we're going to have to bring in more folks for testimony. And this would be a really good way to focus in and say, hey, we need to hear more about this, or I don't understand this. Okay. Section 1 deals with medical care, all medical care. It's not MOUD. It is medical care of folks who are incarcerated. So whatever is not underlined is current law, and what is underlined is what is being proposed for change. So if we could start reading that and see where people are and ask questions, even if it's current law, ask questions, because we need to understand the process for when someone comes in to an incarcerated setting, what occurs with their prescription, what occurs with their overall medical care.
I have a most basic question. Do we have any idea what percentage of incarcerated people will be eligible for Medicaid when they get out?
Virtually all.
Virtually?
Probably
I can't say 100%,
95%.
but Imagine the best.
Therefore, virtually all of them must have a social security.
I knew this was coming.
Therefore, however, we're gonna get that social security number.
But I think you gotta let go of that.
I just, it's.
DOC doesn't care about the social security number, right?
They don't
Isaac?
care or they can't get it.
What would you use a social security number for? DOC?
Basic identification.
Ask our operational.
I don't think there's anything you would use.
They
it
just give
for.
them another number. 'Cause
I understand that.
Yeah.
Okay.
But I know what you're getting at.
So virtually everyone that gets out will be eligible because they haven't made more than $15,000 a year in prison.
Right.
And
Well,
so,
if they're part of a
Kids
family,
going
if they're part of a family, it's a different
Sorry, we could fix that.
dollar.
Please put the comment on, they don't make 15,000.
okay, so.
I mean, some of them.
You save a lot on Medicaid that way.
Some folks,
There you go.
married, some folks are part of a family, so I think it's up to 30,000.
So there's enough people to make this effort worthwhile, not doing it for 2%. Is really where it's going. Okay, got it.
So when a person comes into DOC, they are provided healthcare. DOC needs to provide healthcare for inmates in accordance with the prevailing medical standards. That means whatever we get on the outside, they get on the inside. An inmate means everyone. Offender, it means a sentenced, and it means a detainee. Okay, we're on page 1. You have to be very clear when you hear the words offender, inmate, and then there's a definition for detainee later. So do people understand what lines 18 and 19 are saying? On the first page.
I'm beyond this. I thought we were reading, we're gonna go page by page.
Page 1. Okay, lines 18, 19, and 20. What does that say? People know, or you want to figure out what it says?
It's requiring DOC to enter into a memorandum of understanding.
Nope. Screening for substance use disorders shall be conducted in accordance with section 801B of this title. What is section 801B? Page 1.
Yep, see, easy to skip to 6,
Looking at the wrong thing.
page 6, line 10 there.
Draft 1.1,
That's my fault.
forgive me,
Yep.
sorry. Draft 1.1.
My fault.
It's totally different than the bill is introduced. If you get the bill is introduced, we're doing a strike off. So it's totally different.
You have draft 1.1, yeah, okay.
Total strike off. What does that say on line 19? Screening for substance use disorders shall be conducted in accordance with section 801B of this title. What is 801B? Why don't you go to page 6? What does it say? What does line 19 mean? Trying to help you folks understand the bill. So whoever explains it on the floor knows what we're talking about.
On 19?
Page 1, line 19,
Oh,
page
page
1, what does that say?
What's it?
Well,
Substance
they have
use
24
disorders.
hours to be screened.
Yeah, it's
Wouldn't the 2 weeks go into one day?
Where's the 801B, correct?
It has to be in accordance with section 801B. So what is,
which is a substance use medication for opioid use disorder.
and it has to be conducted in accordance to what's laid out
Within 24 hours.
Yeah, so 2 weeks to
in
one.
section 801B, which deals with your MOUD section, which is from page 6 to page 10, 11. So it's the whole section, not just one piece of it. Okay. So upon admittance, they also have to be screened for MOUD. It has to comply with the law that we put in place for MOUND. So a correctional facility shall have on staff at all times at least one person trained in emergency first aid. I'm assuming, Isaac, that you do that. So Isaac, on page 2, Lines 11 through 13. Department would establish and maintain policies for delivery of healthcare in accordance with the standards in subsection A, which is the provision for medical care. How do you folks do that?
I believe those policies are on our website, and I think they're also included in the contract that we have with them.
So is that in your directives and policies?
Yes, which are publicly available on the website.
They're not your rules. They're not administrative rules. There's directives and policies within DOC. How many directives and policies do you have total?
Oh my gosh. At least like 350 or 400. There, we have a specific process, policy making process, but they are mostly public. There are a few security related ones that are not public. But the vast majority of them are available for the public. There's a on our website, you can navigate to that page and search all of our available. I can see how many there are.
I just think it's important for the committee to know that DOC really operates based on their directives and policies that they promulgate. It's not on administrative rules, some is, but a lot of it is done internally with their directives and policies. So I brought that up because I think it's important for committee members to realize that. When do you find that out?
Yes. You can read. We've got. Let's see, 7 that relate to the commissioner. 23 that relate to human resources development and personnel. 28 relate to administrative services. 259 that relate to correctional services.
Let's see the last one, say that.
4 related to interim memos. Where were those? Yeah, so I'd say roughly 400 or so.
And do you bring this up, Chair, just so we understand how it works, or do you bring this up because it might change substantially when the administration turns over? Or the commissioner turns
Well,
over?
I think it's, I think we'll get into, as you get further into DOC issues, we'll start saying, well, what's your directive say?
Yeah.
What's your policy? If you haven't been exposed to it. Because other departments and agencies don't have directives and policies like this DOC does to carry out how they implement state statute.
We have a team that does that, policy development unit.
And that's what correctional officers have to abide by. It's what staff have to abide by. They have to know those directives and policies. And that's part of your training at the academy too, right? So it's all interrelated. So that's why I brought it up.
We do a process for which when we amend those policies, and send them to the incarcerated population to get feedback if they relate to them. There's staff comment as well. There's an executive review. It's a very kind of structure. It can take many months to update the policies. Not quite as in-depth as statute, but we certainly have our own governing policies.
And inmates, if they sue the department, go to those directives and policies. They go to that. Or if they write a letter to you folks, they'll indicate a certain directive. So it's really good to know that there's layers here. So if you go to line 14, pre-existing prescriptions. This is really important for when a person comes in and they are currently taking medication. You need to understand this language.
And they have to provide that information voluntarily.
It's voluntarily.
It's gotta be real, valid, not 2 years old.
I mean, they can do, the department can do their own look into the, whatever it's called, it's down there on page 21, the Vermont Prescription
Monitoring System.
So it's not always gonna be self-reported.
Right.
The department has the ability to confer with an inmate's incoming, their healthcare practitioner.
And do they?
That's a question.
And do they?
Confer with incarcerated people about the prescription monitoring.
No, with the other sources to get the information that
I think Dr. Uliger, who touched on this a few weeks back, said it's something he wants the medical staff to do more. Just confer with outside providers, people's previous medical providers.
So you're doing it somewhat now, somewhat.
Right.
So in the future, you're looking to do it or
Because what Dr. Uliger mentioned, yeah.
So within, I'm sorry, go ahead.
No, go ahead, no, you go.
Within HIPAA, Vermont Prescription Monitoring has this information. And it's tied to the outside world with what number? This 5-digit number that we assign when they get incarcerated?
No, no. When a person comes in to be incarcerated, we worked on this as a committee with this language in it. When a person comes in and they're asked if they're on any prescriptions. Yes, these are the prescriptions I'm on. The provider can reach out and they would ask the person, who's your medical provider? Who's your primary care provider? What pharmacy do you go to? The testimony we received years ago was that the contractor, DOC, the healthcare contractor, would connect with that primary care provider to find out, is this person one of your patients? Is this person taking this medication? And to validate it's a valid prescription. They can also reach out to the pharmacy that the intake, the offender is saying, and they can reach out to the pharmacist as well to see if this is a valid prescription at that pharmacy. There are times that there is no primary care provider for the person, but the person says that they have a valid prescription. DOC will call that pharmacy and the pharmacist could say, well, it was valid 2 years ago, but we haven't seen the person. Or, yes, it is valid, person hasn't picked it up for 3 months. Then DOC will evaluate that and do further screening and assessment to determine what medication the person needs. Is that fair to say that that's the process, Isaac?
Yes.
And then whatever they find out goes into the Vermont Prescription Monitoring System?
I don't know how DOC does that. This is another
We're getting a
way
little
of,
technical for
Yeah.
my expertise. I'd have to.
so what this is bringing out is we need more information from DOC in terms of how prescriptions are verified.
And we'll be here, was it Thursday?
Thursday
Yep.
after the floor.
So Viva will be here and she can.
And my question is, well, I had a belief until a minute ago. So now I'm questioning. You can only check these prescriptions, et cetera, if the inmate gives you permission. Or, right? Or you can do it no matter what. Like, so in other words, like my doctor can't go to my old doctor and say, could give me James's records without me saying it. And that was my impression originally, but for some reason, something that was just said makes me think that it doesn't entail that.
So I know Brendan will also be here. She's our nursing program director. She would be a good person. She will be able to walk through in detail, excruciating detail, how we validate prescriptions and
It's a great answer, Isaac. I like it.
you don't want to hear it from me.
excruciating. That's what it is.
So what we need is more clarity in terms of what that process
Yes.
is to verify the prescription. Can they actually call the inmate's current provider who's on the outside? And if they can't get any information from the primary care provider or the pharmacist, do they then go to the Vermont Prescription Monitoring System? That's what we need to know. So Gina, you had your hand up.
James asked the question.
You're gonna try to steal
It's the ESP, James.
it.
Wonderful minds think alike.
Talking my mouth.
Yeah. That's all you can say.
And remember, wherever we have said healthcare practitioner license to prescribe, We have expanded supposedly, though it's not in this draft, but we've talked of expanding the definition of healthcare practitioner to include the individual scope of practice.
I think we agreed that that's gonna be in the definition section, and then we're just gonna refer to them throughout the bill as healthcare practitioner, right?
Yes.
That it's on page 4 is the definition of healthcare practitioner.
In my notes.
Let me just, I'm still on page 3. I have 3 questions and I don't know if I have an answer.
So on page 3, I haven't even got there yet. Okay, but
We're kind of moving there.
Okay.
Yeah,
Question that I have written down is, does this create an exception for the requirement of a prescription?
what line?
where?
I'm at the, my notes are in the top of the page margin. And it's also, again, same question is gonna come up again on page 7. You repeat the prescription. Does this create an exception for the requirement of a prescription?
Hmm.
According to the testimony we heard, it can't.
We also did receive testimony that DOC has the does have prescriptive authority. I think I'm answering my own question there, but I just can't remember the situation where I was writing these notes.
Well, that's why we're going over this, so that when we hear further testimony,
Of course, medication shall be entitled to continue that medication and to be provided that medication by the department pending an evaluation by a healthcare practitioner. So I think I answered my own question based on testimony we received from OPR. So that first paragraph
Mhm.
does allow for the Department of Corrections to write a prescription based on their evaluation by a healthcare practitioner. And I do have an answer in my own notes that DOC does have, or in this case, WellPath does have prescriptive authority. So it could be true that a person is screened for opioid use disorder, doesn't have a current prescription,
Mhm.
and may be assigned one.
Yep.
as long as a healthcare practitioner is working within their scope of
Right.
practice.
Yeah,
Because I think part of the question came up with the director of the medical board,
yeah.
which was a hard testimony to follow.
Hmm.
And then another question along those same lines, can DOC keep a stockpile? I don't have an answer.
They
But
do,
yeah,
Yeah, I
they
mean,
do. It's the only thing well, you do now a little bit of methadone, right?
Right, that has to be, that's provided, I think, by the hub. Which
But you
comes in
can
with-
store it on site as long as you pick it up from the hub. Right?
It requires refrigeration, so I'm not sure what our facilities have that resource.
But you pick it up from the hub, because before what needed to occur, it was the inmate had to go to the hub
Mhm.
with correctional officers to get the methadone. And then we worked up a system that at least that could be picked up from the hub.
So is it specified someplace how long the correctional facility can hold it after they get it from the hub?
For the methadone?
Yeah.
That would be a question, what that process is, the methadone.
Bring it up because that definition then really gets fuzzy. Who's holding it?
I think that goes back, Representative, to the questions we talked about in the first draft of the bill on the opioid treatment provider, the federal designation that Dr. Jimmy Fallon talked about. That's why we use the hub, because we're not licensed to dispense methadone.
Hmm.
You need a certain licensure to dispense methadone.
Yeah.
But you do dispense methadone
Through the hub,
through the hub,
right, it's covered, I think, by the hub.
but you have it on site. Correct?
Yes, it's done on site.
We need to figure, I've got a note here, what's the methadone process? How do you get it? How long do you have it? So lines 8 through 12, the department may defer provisions of a validly prescribed medication if in the clinical judgment it is not medically necessary to continue the medication at that time. A person could be coming in with a valid prescription, and the department could defer that. So you might want to ask some questions on that one, folks.
And if you get a new medical provider, and they may have a different opinion, I don't know what sort of question to ask.
If they're able to prescribe, they ought to be able to defer.
Correct.
Mhm.
Then if the person who's incarcerated says, no, but I really need it, then who do you go to? Or does the medical practitioner have the final word?
Well, that's interesting. Yeah, Isaac, are there second opinions available to?
There is a medical grievance process. I assume you could probably appeal. I think it's laid out in statute here that reasons you to reason the discontinuance.
So how smooth of a process is that? Probably not.
No
Everything
rhetorical
is
questions.
Go down to,
You could argue about everything.
if you go down to number 3, the healthcare practitioner makes the clinical judgment to discontinue a medication. The reason has to be entered in the inmate's medical record. So sometimes what you see, I think, in DOC, in the discontinuance of medication, is maybe DOC doesn't carry that particular medication, but you have a substitute. So that language would address that situation. And sometimes does this happen very often where DOC or the medical provider would say, no, we're gonna discontinue that medication because we don't find it medically necessary? Does that happen a lot?
I imagine it could happen that the case in which I'm most familiar with discontinuing medication actually revolves around ADHD medications when there's a national shortage. It might have happened a few times, but I know we were worried that we wouldn't, and I think people in the community were worried that there wouldn't be enough medication, like Adderall, Ritalin. And so I remember we put out messaging to on all the tablets and in all the units, letting people know that there could be potential interruptions to their ADHD medication because of the supply shortage. And I'm not sure to what extent that actually happens, but we do this with risk. In regards to other medication, that would be a good question for Brenda specifically.
That might be helpful because I know there was a time when a lot of folks who were incarcerated were saying, my medication has been discontinued and it's wrong. And this language here on page 2 and 3 was a way to address that.
Well, this makes me think specifically about the possible switch from injectables to sublingual. And with this, I mean, that's going to come to loggerheads with best practice, right?
Yeah, I wasn't thinking of MOUD at this point. I was thinking of general medical care.
Mm.
Because this section pertains to general medical care. The MOUD is in section 2. Okay, this is general medical care. This is your medication for blood pressure, cholesterol, ADHD, all of that. This section does not pertain to MOUD.
Potentially as well on Thursday, Brenda and if you could talk a little bit more about the medical grievance process, which is separate from the regular grievance process and ways in which someone could appeal on this issue.
That's why I wanted the committee to be clear. We've got two separate sections here. The first section is medical care.
Is the inmate's medical record analogous to the Vermont prescription monitoring? Is it the same database?
No,
No, it's
Oh.
you use electronic health record, correct tech. Which is a electronic medical record system. We operate.
that you operate, DOC operates, which is different than what we have on the outside. DOC has their own.
Just like any hospital has their own EHR system.
The prescription, Vermont prescription monitoring system is the state of Vermont. Our provider could go to that. We're saying also the DOC provider could go to that to verify the prescription. So we're ready to move to page 4. This is your definitions section, and this is something we really need to clarify. Do we want a definition of detainee or not? In other parts of DOC statute, there is a distinction between offender and inmate, and we had carried that distinction through in the medical care as well as the opioid care.
I think it should be consistent across the board.
So are you saying we keep offender and inmate, or are you saying we change the rest of Title 28 for detainee?
Isn't it appropriate just to have in what a detainee is?
Well, that's what Katie has done for this particular section.
Right.
Detainee, she carved out that there was a definition for detainee.
Right.
I thought I learned that the definition of detainee could be a very short-lived incarceration. Therefore, MOUD would not apply.
If they're there for 3 years,
They're an offender.
no,
No, not
because
necessarily.
they haven't been
You're right, you're
sentenced.
right.
There's a lot of detainees.
Right.
There's detainees that come in on a Friday night that could be gone Monday morning. There's someone that could be there for 3
Right.
weeks or a month and then they made bail.
So detainee is not the correct term.
The way that Katie has defined it means an individual incarcerated awaiting trial. But they could also be carrying a sentence. And were out on furlough and committed a new crime, and now they're a detainee as well as serving a sentence. Welcome to the world of corrections.
You see that in our public data, if you go look at our research and data page. There's a lot of different legal statuses you could look at, like sentence hold, that's usually how we refer to it. Someone's incarcerated, so. You may also have pending charges, and sometimes you also have someone who's pending charges. They're, currently incarcerated.
So for a detainee that is there, hasn't been sentenced, therefore is not an offender, but it's been there for an extended period of time, we want MOUD for that.
That's medically necessary.
Right.
Yes.
So don't we need to specify how long the detainee has been detained?
Good luck with that one. Right, Isaac?
Well, that's the question.
So that's,
Answer, how long, when do we put ourselves on the hook to provide this extra service.
I thought this screening was going to occur within 24 hours, assuming it was able to be done, as opposed to 2 weeks, which was the previous.
And we do that for anyone who's in our custody, regardless of their legal status. And oftentimes WellPath does not even know who's a detainee, who's a sentenced individual, and I think, we try and treat everyone the same regardless.
But I do think it's important you're consistent with how you're going forward. Because just like hearing earlier in the discussion, folks have left different agencies, and so no one's really knowing what's going on. So I would think we would want to keep language within here, this to make it consistent so we know what we're doing going forward, no matter who's there.
So in Title 28, general definitions. Inmate means any person committed to the custody of the commissioner and subsequently committed to a correctional facility, and any person confined at a correctional facility during the pendence of a prosecution against him or her. That's the current definition of an inmate,
Yeah.
which is basically a detainee. And an offender definition means any person convicted of a crime or offense under the laws of this state. So
I mean, I think it's the intent of the legislation to cast as wide a net as possible, right? And so we're looking for that word, which I think is detainee.
yes and no. What you have to do is you have to read the law. And in some places it says offender, and in some places it says inmate. That's different categories.
But detainee subsumes both of those, does it not?
No, a detainee is basically an inmate. An offender is a person who's been incarcerated. So, I mean, a person who's been sentenced. I think it's important if you saw another part of statute in DOC to understand. And I'm trying to find,
Just so you're aware, I don't know if this is gonna help or not, but anytime detainee is used, now I'm gonna correct myself. With one exception, within this bill. It is because the language is offender or detainee,
within
with
this,
the exception of release. Where it says may provide the detainee, and that's where I've asked if we want criterion or not. So within here, there is always a distinction between offender and detainee.
but not the rest of Title 28.
Right. So if we're going to continue to, and there's a very specific reason on line twice in here, when we're talking about release, where the DOC is potentially exempted from providing a detainee with continued medication. We just don't have criterion for it right now. So that's why I think it's important to keep detainee in this bill, because it's going to be a very specific conversation we have as it relates to providing medication upon release. Does that make sense?
Isaac has his hand up.
Go ahead, Isaac.
I think, the department is relatively agnostic to the definition change. I mean, I think our legal counsel will be able to speak to this more on Thursday. They're coming in with our medical folks, legal counsel, but I think there is some merit to defining detainees. We think about detainees a lot. Obviously, they're a complex population. And so maybe fine tuning statutes kind of specifically address some of the challenges that come up with detainees is not a bad idea. I think generally we're neutral though and defer to your expertise.
Well, and so Troy, going off of what you were talking about, would we then use offender or detainee throughout, except in the two instances considering release?
In here, yes. In this bill, it's
Yes.
either offender or detainee with the two exceptions where
Yes.
if we're talking about exempting DOC from providing detainees with medication upon release. And again, the criterion for me, I think, is going to be like if a detainee has been there for 4 hours, you're not going to necessarily give them a week's long
Right.
supply of medication. Right. If a detainee has been there for, I don't know what the criterion is, but the only place a detainee is not. Yeah, I've answered your question.
And so the one word that I was seeking doesn't exist, which is why we have to use TDA or offender.
In that case, when we're talking about the release protocol, separating out detainee is going to matter.
Yes.
So what you're saying is for these two sections, for 28 VSA 801, which is medical care of inmates, and for 801B, which is for the MOUD, for those two sections, we put in a definition of detainee, but not for the rest of Title 28.
I think I agree with you. And I think it's important because the bill intends to stipulate the difference between release provisions between offenders and detainees. And the only way to do that is with detainee being defined.
But then the question is, how do we define detainee? Because it's not just someone awaiting trial. Right, but it's not
accurate.
It's not accurate. It's not accurate.
Now I'm confused again. Couldn't they be detained with waiting for trial for an extended period of time?
Yes,
But that doesn't.
but,
So why
but
would we?
they may have already have an underlying sentence. They were out on furlough and they committed a new crime. So would they still be classified as an offender?
So in ours, it's sort of similar to how when you have a lot of different charges, like when we're showing you, who's been convicted of what or who's for what, we usually we revert to the kind of what we call like a driving charge, or when we're looking at our own data, we would also in this case sentence with a hold. So they're technically an offender, they're a sentenced person, but they're also facing they're pending criminal charges as well. So in that case, they would be an offender for all intents and purposes.
They're still awaiting trial.
They're still awaiting trial. I mean, technically they're both, but the driving charge or the driving legal mechanism here is that they are already convicted. So they would be a sentenced person. But when we, if you look at our website, when we break out all this data, we have separate categories for people who have multiple statuses like that.
I'm looking up where detainee is defined, if it is, and I came across the term home detention.
Right, and how is it, yeah, right, how is it defined in home detention? As we did, how is it defined in home detention? What part of statute is that? What?
Vermont state, I just can't, that is crimes and criminal procedure, Title 13.
That's in Title 13, right? Right.
Is it our intention for a first time accused who's held for a week to receive MOUD?
I think it's our obligation.
For 1 week.
If they come in
First
on
time
it,
they're coming in, they're in there for 1 week. We're gonna provide them 30 days worth of medication.
Well, that you're talking about
And try to
release.
get
talk
them on.
about reentry on
You're
that
talking
one.
about release now. I don't know the answer to that question. I'm saying while they're
Question to
there.
ask DOC when they come in.
Well, as the sponsor of the bill, is that what your intention is? Is that a person who's detained for 1 week, first time, hasn't been charged, that we're going to provide them medication for a specified period and try to get them onto Medicaid?
I think you have to look on 801B.
It's the correct, they have been charged.
Yeah.
And they would receive medication
Yeah.
if it's medication.
Any medication,
and
It's
that's-
necessary. If they're being held by the state has to provide that. Upon release, I don't know. Right, we have.
Oh, yeah,
we have to come
I'm
with
sorry,
a-
yes,
yeah,
upon release. They've been detained for 1 week,
Right,
first offense. They haven't,
Yeah, that's my question. That's precisely the question I had been asked, and that we haven't talked about yet as a committee.
The existing languages, they put into place in the last
It can't show up
section.
here.
Medically,
okay.
medically necessary.
Medically necessary. is-
Provided 18.
And there's a definition for medically necessary.
Yeah.
There is a definition for medically necessary.
Mhm.
So maybe we need to know what the definition for medically necessary.
Yeah.
Oops.
All I'm seeing, and I know this isn't necessarily true for definitions of detainee, kind of all center around anyone who's being temporarily held or detained until they can be tried in a court.
What section was that home detention one in Title 13? Do you remember?
Chapter 57. Well, I don't know, just hold on.
57?
Click wrong, I may have clicked wrong.
That's larceny and embezzlement.
I see,
know.
I just see it actually not defined, but used in 7554. B,
7554.
yeah, in Title 13, which is the detention statute. But it's not defined, it says deeply.
Lost my original. I backed out and now I can't find.
There's no definition for detainee anywhere, right?
Colchester defines it. I don't know why.
Okay,
Yeah, I'm not finding.
I think Title 13 actually has a definition.
so if we keep the definition of detainee, then we really have to work it through. 'Cause what Katie put in there may work and may not work. Okay, it was Katie's attempt to find detainee. Just because it's down here doesn't mean it's at. Okay, so we can flag that.
Mhm.
Let's keep going. So we've updated the healthcare practitioner. We updated that definition.
Well, we haven't seen it yet. but it's
Right,
being-
so what it would read, it would mean an individual licensed or certified by OPR or the Board of Medical Practice and acting within the individual scope of practice.
Lawful scope of practice. I got.
Was it lawful?
Yep. She said lawful scope.
That's what I've got.
Okay, sorry, what page you guys on?
Oh, that was suggested to us by Sheila. Hold on, let me see. Sheila.
Yeah,
So that clarifies the different levels of licensure and also within those. Okay. So wherever the term healthcare practitioner is used throughout this legislation, this bill, this is the definition.
You want me to read the definition as provided by OPR?
This all gets.
I would love to hear it personally.
And then. yeah.
What was that, Troy?
She did give us suggested, in her memo, Sheila, did give us executive officer, board of nursing, gave us a suggested title, and it is as Sean recited. Healthcare practitioner means an individual licensed or certified by the Office of Professional Regulation or the Board of Medical Practice, and acting within the individual's lawful scope of practice. That's what was suggested during testing.
And their license. That's what I have. That she may not have it there, but And they
Yeah.
testified here it's an N license,
Yeah,
but that may not be necessary.
yeah, individual license or
If
certified.
it's your lawful scope of practice, you have to be, wouldn't it? It's a question.
I mean, I think Katie took that with.
Yeah, that was David Hurley, he married, right?
Yes.
Yeah.
So does it read acting within the individual's lawful scope of practice?
Yes. Mhm.
That's the way it would read. Doesn't talk about license, right?
In the previous sentence, it does.
Right.
Means an individual licensed or
Right.
certified by the official,
Right.
by the office,
Mhm.
professional regulation.
Mhm.
There's an of missing there, right? Line 8, page 4. Office of Professional Regulation.
Yeah.
It's the office, it's OPR. I think
By
it's,
the.
office of
By the-
Professional, yeah. By the office.
Yeah. it's called OPR. I don't know if there is a.
There's not.
Is there?
There is.
How would you say it in that sentence?
Yeah.
You bring that up with Katie. So if you go to page, you go to line 11, here's your definition of medically necessary, which is really the crux of decisions that are made for their average prescriptions, for medical prescriptions. It's also medically necessary in terms of MOUD. So you really need to understand this definition because that's what we fall back on. Has to be medically necessary in order for any of those prescriptions. That makes sense for
Mhm.
folks?
Yeah.
Yeah.
This one looks good.
So then. I'm going to Title 18, Section 47. Everyone knows how MOUD is defined. No, it's not. You have to go to 18 DSA. You have to go to the statute. Okay? And the definition that is in statute for MOUD means the use of U.S. Food and Drug Administration approved medications in combination with counseling and behavioral therapies to provide a whole patient approach to the treatment of substance use disorders. That's what MOUD means in state law. It's not any different in DOC than it is out in the community or anywhere else.
Yep.
It's in Title 8, Title 18, which deals with health, and it's Section 4750. And that's your definition of MOUD. So we've carried that same definition that's used in our world, the outside world, we've carried that into DOC. Okay. For page 5. So Troy, I think you had a question on line 4 on page 5 about the word thereafter. Does this also entail reentry and beyond?
I don't remember if we came to a decision. on
We didn't. I still have it flagged. So Isaac, how many contracts does DOC have between DOC and the provider of physical and mental health or substance use services? Those are folks on the outside. These are external medical provider contracts. Do you have many?
And that'd be a good question for Aviva right now. I'm not sure. I mean, we have the agreement with the hubs to provide methodology.
I know this is tough for folks, but it's really, you gotta understand this for when
Mhm.
folks come in and testify.
Oh, yeah.
Because somebody's gonna, if we vote this bill out, somebody's gonna report it. It's not gonna be me, and it's not gonna be true. Connor. Don't be one of you folks.
He's general. I don't think it's that common.
Why isn't it Troy?
What's
He's
that?
the-
What's that, Isaac?
Kinda
I don't think it's
common,
very
uh,
common with a third party, other than with the hub licensure of the OTP. Because since there's no Medicaid, there's no payment for a lot of outside external providers unless it's paid directly through the state or through the contractor. But
Would that change with the 11-15 waiver?
it's a good question, I'm not sure. Potentially.
Sure, I can't remember if we talked about this specifically, but would through release or
Why would
re-entry?
the waiver is so they start prepared for the.
The two.
Hang on, we got two conversations going.
Right.
No, you started and then you
Okay.
started, so.
Go ahead.
Yeah, but I was sidebarring like a jerk, yeah. And I'm just wondering if going to through re-entry or through release covers what we mean and removes the kind of the weasel word thereafter.
Yeah. That's a good point.
Well, you're contracting with an external medical provider with a continuation of medication at the time of admission and thereafter.
I mean, we want it to cover through release, I think, but thereafter can look like till the end of time or something.
So I've got that flagged. Fast.
Mhm.
So what were you asking, James?
Well, as Isaac, the question that came up about whether or not it would change the third party because of the 11-15, but isn't 11-15 and basically gives you the ability to basically line them up, if you will, for Medicaid when they get out. So they're not really,
They're
Also,
getting
it's 90
Medicaid.
days prior to release.
They'll get
oh,
Medicaid.
90 days prior.
But the way that we're structuring, again, it's getting pretty technical, the payment mechanism, I think is gonna be actually a retroactive payment. Where essentially we'll get refund, like WellPath, because we pay a per member per month to WellPath. So it's something around $2,000-$2,500 per incarcerated to WellPath for everybody. It's like a flat rate. And so I think the way that they're gonna do it with the 11-15 waiver is that when someone actually releases, because release date is kind of a moving target. So it's hard to say exactly when someone's gonna release with good time, Thursday or time. But when someone does release, then we'll basically get all their health services, with like the 90 days prior reimbursed through Medicaid. That's
You
how
pay it
they-
up front.
So
You
we'll
pay
it
the
up front,
$2,500
and then
per
we'll have a
person
reimbursement process.
per month up front, and then when the person does get released 90 days later or thereabouts,
That was the initial design,
then you get reimbursed for that amount for those 3 months.
because it's very difficult to know, is this person really gonna release in 90 days? And what if we're off by a day or two?
I understand.
So I think it's gonna be clear, but
Okay.
that kind of thing, we're still gonna be working with WellPath, so there would still have to be, or contractors, there would have to be an outside entity that's working with that contract. It would be complicated. So I don't see it really happening that much. This language, which is current, obviously this is current statute, it's not underlined, hasn't been an issue that I know, so I'm not overly concerned with it.
Okay. Thank you for that.
So line 7, G, prescription medication, this is for their reentry plan. And the key for this was the continuity. Just keep them on the medication once they reenter from an incarcerative setting.
Not.
Right. Because there was a lot of holes that were being created. People were not getting their medication when they were being released from an incarcerative setting. So this is important. This is important. On lines 8 and 9, the way the current law reads, if an offender takes a prescribed medication while incarcerated, offender means sentenced person.
Mhm.
This section does not pertain right now to a detainee. And that was purposely done. That was purposely done last year. Because we don't know the time frame that detainees are held.
Right.
And the testimony we received from DOC was they could be there 2 days, they could be there a week, and they would be released by the court. And we wouldn't have enough time or even knowledge of how to prescribe. Sometimes they're gone from the court, they don't even go back to the correctional facility. That's why we had just offender and not detainee. So we gotta flag that one.
Or if we come up with a criteria and we say detainee in excess of X number of days. Or something to that effect.
They can still leave from the court. Poof, they could be there for 2 months, make bail, poof, they're gone.
No, I
DOC.
understand, but if they're there for a certain amount of time waiting for the court,
But they could be there a month, they could be there 9 months, they could be there 2
Right.
years, 3 years.
right, so as long as they're there longer than X number of days, it applies, does it not?
I think we would have
Is that what your
preserved.
intention is?
No, let's look at DOC here, because they have to administer this.
Yeah, I think the way it's currently structured here is fine. And. we
Which
talked about
current
it.
law or new law?
I mean, I think either, because this, I think, sets into statute what we are already doing, which is that we must provide the offender, and again, these are people sentenced, we know when they're going to be releasing generally, and then we make every attempt to get the detainee who's releasing bad medication, but it's not always possible, to the chair's point. Folks go to court and then suddenly they're released, the charges are dropped or they may fail. They might have to come back to the correctional facility to pick up their meds, which doesn't always happen. So this language is fine as, I think, as is written into the bill here. It may provide the detainee,
Yeah.
we just need a little bit of wiggle room.
Right, that's a key
Needs some
provision.
discretion.
So you're not worried about the lack of criteria?
Because, like he just pointed out, the key part is on 12 and 13, where shall provide to the offender and may provide to the detainee.
It gives them an out there too. My worry is the folks who have been a detainee for a number of times, have gotten onto a treatment plan through the DOC. There's not necessarily currently an obligation to make sure that detainees who fit that category are provided with medication upon release.
Which is where Kevin's idea of detainee that's been there for X amount of days now is eligible.
Right, and I'm willing to have that conversation.
That's gonna be too tough.
Yeah.
The facilities are already.
I'd say it was, I'm just saying it triggers Kevin's
And
idea.
these aren't even state employees, right? Some of them that are doing all the medical, these are contractors. So I think,
I understand.
May provide the detainee.
I think.
So let's flag this, folks. The exercise today is really to flag where we need more testimony and clarity.
Mhm.
Hang with DOC, nothing is linear. Right? Nothing is linear. So let's move on. And so when a person re-entered, top of page 6, when a person re-entered. Now this currently is the department or its contractor. Now we know that the contractor, well, this is also, this is also on page 5. Right now, it's the department or contractor that would provide the person with the medication upon release. It's also the department or the contractor would identify any necessary healthcare practitioner and schedule an intake appointment. So the argument has been made that the contractor is under the department. When we looked at this last year, we wanted to track to make sure WellPath, the contractor, was the one that was doing the work. And that's why we put the department or its contractor. If you take out or its contractor, does that imply that it's the department that's responsible?
Feels like
Which
it.
in essence they are through the contractor, but it is the contractor that makes the actual outreach and prescribes the medication.
I mean, it feels that way, but doesn't mean it is.
So do we keep it as current law or do we take out the contract?
Does anybody have the context about why that was struck, or was that just Katie's?
That was Katie's saying that the contractor is under the department.
And I would agree that that's true, but I also don't think it hurts anything to be clear that it's, that we're, you know, in this particular case, adding is not necessarily a subtraction, where sometimes adding is a subtraction.
Are you suggesting keeping it in, or?
I would keep it in personally. I don't think that it's harmful to take it out. I think she's dead right that anything under the department is responsible to them, but
I agree.
I think it's fine.
Keep the contractor in there.
Yeah.
I mean, we were clear about this last year.
Yes.
Oh, yeah.
I think the department would have a slight preference for keeping it in, so that, you know, there's a greater emphasis, obligation, legal obligation on the contract.
So we take it out?
Services.
You said,
We'll do it.
unstrike it.
Unstrike it.
But I have a question. I know this is like the little detail. But why wouldn't you do instead of or its contractor and?
What do you mean, and?
because it means both of them have to do it at the same time.
Cause this
You don't
way,
have both of them doing
You
it.
wouldn't have both of them doing it because it's duplication of work.
It's WellPath that doesn't.
okay. Thanks. Yeah, I
WellPath
just
is
was
the
wondering.
one, so you're saying the
I'm just like-
department and
It's like,
WellPath.
so think of it this way, Sean, like.
Well, cause then they're both, then one can't blame the other for not doing it.
Yeah, but think of it this way. So you and I are.
No, okay. I'm just throwing it out there.
If you and I are on a construction site, just pretend, and somebody needs to go get a hammer. If they say Sean and James go get the hammer, we're both going. We have to go.
Hmm.
Sean or James go get the hammer.
Right.
Only one of us goes. So it's that kind of.
Yeah, we do, you know, this piece of statute, we build into the contract. It's directly built into the
Okay.
contract with WellPath.
I was just asking. So,
Do you have a question, Will?
Yeah, are there ever instances where DOC and the contractor do have that joint responsibility? I get that, you know, there's gonna be some instances where the contractor's performing it and you guys would just contract it out. But is there an instance where they're kind of tied together where it might make sense to say the department and or its contractor? I know that's probably not how you put it in statute, but I don't know if there's an instance with that exactly.
I mean, I think essentially it's kind of semantics
Okay.
at this.
Oh,
okay.
oh,
It's the contractor that does the prescription. It's the contractor that will hand out the 28-day supply. It's the contractor that will notify the offender's primary care provider if they have one. And any substance use treatment program that's out there, or the local turning point or whatever, or the local designated agency, and say, hey, this person's reentering. That's up to the contractor to do that.
You could say the department via its contractor, and then you'd do both.
You do.
Yeah, sometimes you have to go for
Like
it.
425.
Just want to keep. So let's keep working about 10 more minutes. Does that work for folks?
Yeah.
Okay, section 2, this is our MOUD.
Yay.
So we're finally on the MOUD. So within 24 hours, each inmate. So we're using the term inmate in this section. We're using the term offender, and we're using the term detainee. Inmate means detainee and offender. Offender means a sentenced person.
Hmm.
Okay?
Eight oh one again.
What?
I said, there's our section 801 again.
Well, we've deleted the old section.
Yeah.
Already there, I've got on line 16,
Hmm.
the add in this case, or its contractor, the department or its contractor shall determine whether an inmate is currently using medication.
We're getting head shake back there, so that's a good thing.
I think she caught that, double that. I'm sorry, I'm on page 7 already, line 1.
She did.
I think you caught it last time. Line 1, page 7, is redundant that.
Yep.
So an inmate who's receiving MOUD prior to entering a facility shall be entitled to continue receiving that medication pending an evaluation by a healthcare practitioner licensed to prescribe the medication.
Yep.
Do you want to strike that license to prescribe because doesn't that fall?
Somewhere else.
Oh, yeah,
Because
It's already defined.
that's in the definition of healthcare practitioner. Yeah.
And the pending an evaluation by a healthcare practitioner licensed to prescribe the medication for as long as medically necessary. So then you have to go back to your medically necessary definition, because that's your trigger. That's the trigger.
well, I think Brian's point on the line 2 is everywhere else, the healthcare practitioner, we define the license part in the definition, so he says that should be struck out, license to.
Yeah, that's what I'm on about.
It's redundant.
Just like we're not adding scope of practice.
Right.
Right.
Because it's in the definition.
Yeah.
So the way we're using healthcare practitioner in here already assumes license to
So
prescribe.
we've used licensed, I don't know about that one.
Okay.
I don't know about that one, because if you go to page 3,
Uh-oh.
I struck it there.
care practitioner licensed to prescribe the medication.
Yes, he struck it.
I don't know if Katie struck it, but I had it
I
stricken
wonder
there
if
as
you do
well.
or not.
Worthy of flagging at least, because that's consistent.
No, it may be, it may not. I don't know. That's a question for
Again.
Katie.
Line 8. We got it again on line 8.
Yeah, so wherever it says. So this, hey, on 6 and 7 raises what Brian brought in. They're entitled to continue receiving that medication. So if they're on an injectable and they come in to a facility, do we continue them on the injectable?
I mean, Tony essentially gave us testimony stating that would be really rare. The question still remains, but
Well, I wonder if there's different alleged counsel on this, but when it talks about medically necessary, the definition includes whether that's appropriate given the setting, we look at the definition. And so I think there's a potential argument to be said that if DOC doesn't, if it's not within our formulary, if it's not a medication that we actively dispense or our contractor prescribes, then it's not medically necessary. And if, especially if there's, so for example, the injectables are buprenorphine and we're offering buprenorphine just in a different form.
Right.
The different delivery mechanism.
But I mean, without getting too weird about it, Isaac, if you extrapolate, if there's no heart medicine available in a correctional institution that is not medically necessary.
But I think the key being that we do offer that medication just in a different form.
Yeah, okay.
That's tricky.
I'd have the same question, Brian.
Yeah,
It would be clinically, because it's clinically indicated, it'd be clinically appropriate.
yeah.
Because there's certainly different heart medications and side effects and everything else. Well, we'll just give you this one instead of that one.
Well, we do that
Yeah,
in DOC. We do
I mean-
that, but it has to be,
do that outside too.
yeah, it has to be a clearer process than what it was before.
We also, not to get too deep in the weeds, but we granted this a little bit with the hepatitis C medications a few years back as well. Because it takes a significant amount of time to work through the treatment regimen for hepatitis C elimination. 4 to 6 months sometimes, depending on, it's like 8 weeks of medication here, and so you do all scans and blood tests. And we found, which for the detainees is very difficult because they cycle out so quickly. So there's just be some difficulty with getting folks on the medication sometimes.
So we'll flag that.
Mhm.
That's another one about injectables, just to be clear. And we'll give you cover, Isaac.
We appreciate it. So hopefully with the waiver, we'll be able to use injectables for the last 90 days.
Yeah.
We can go Medicaid for that.
Time we're done, there's gonna be so many flags, you'll think it's the United Nations.
So while they're incarcerated, if at any time an inmate screens positive is having an opioid use disorder, the inmate may elect to commence medication for opioid use disorder if it is deemed medically necessary by the healthcare practitioner. Inmate would be authorized to receive the med as soon as possible and for as long as medically necessary. So there's that term, medically necessary,
Mhm.
used throughout. That's the trigger.
We've got an extra A in there on line 6 or 7.
6 or 7?
Yeah.
That'll be the only literary correction I'll ever make.
You start,
Yep.
you start with commas, we're gonna have words.
Probably, Brian.
I'm straight.
So if you look at section number 2.
Yeah.
A and B, this is where it's not limited to bupe or methadone. Contains any new medication. And again, it's new medication is deemed medically necessary. So there was a question on the top of page 8. I have a question. Could the provider be an out-of-state person?
Are you thinking Mississippi specifically right now?
I don't know if that's what it came up as. The current law, the
Well,
license,
Yeah, that's the
The
conversation.
licensed practitioner makes a clinical judgment to discontinue.
We did have that conversation and it was, in Mississippi came up because we're like, is their definition gonna be the same as ours? That was the whole conversation we had there. You know, what a healthcare practitioner is based on that particular state was used, but it could be anywhere. Do they have the same? I gotta get going.
Well, I would still have the same question about Plattsburgh or anything else like that.
So let's finish on that one and pick up where we left off, but I've got that one flagged.
So start at 8. That page.
Yep.
Okay.
So thank you guys for hanging in there. I know it's tough, but I hope it helps kind of get your head around the bill a little bit. I hope.
Yeah.
So
buddy.
we're back here at 9 o'clock.
Marching orders.
All in orders.
No.
Thank you. Have a nice evening.
Yeah.
Yeah.
See you, Kevin.
So we're back here at 9 o'clock tomorrow morning.